Yes.
Well, good afternoon to you all, ladies and gentlemen. This is our final presentation of 2023. We've enjoyed presenting to you throughout the year, but we've had a little bit of hiatus in the autumn because, of course, many of you were present at the World Congress in Washington. And by my understanding, the World Congress was a great success. I also understand that the anatomical presentations went down very well at the World Congress. So we're hoping now to build upon what we achieved during 2023. And this final session today, which sadly has been postponed by 1 month, I'm sorry that we were unable to be with you in November. But today we're going to be discussing what is a ventricular septal defect. And this is going to be the starting point of a series of presentations we're going to continue next year. Because what we are going to try to concentrate upon is the phenotypic features of the various lesions that confront you in your practice. And we're going to try and make this simple. So our first sessions next year are going to be concerned with what is tetralogy, what is double outlet, and what is transposition. And then if you are comfortable with those presentations, we can continue and we can emphasize phenotypic features that to our minds are so crucial. And throughout those initial presentations, I'm going to be joined by Diane. As you will see in today's presentations, she can give you the most wonderful video demonstrations of the features of the various lesions that you are confronted with all the time. And we want to expand from this next year. So now, as we approach the festive season for 2023, we wish you all the best for this year. We hope that you enjoy the session that is to come, and we hope you appreciate that that is the starting point, what we hope to achieve next year in 2024. So, to complete our sessions of 2023, we're going to ask the question, what is a ventricular septal defect? And as you see, I've given a very simple definition, a channel between the ventricles that permits interventricular shunting. Now, you know as well as I do that when we look at the anatomy of these various channels, they can take very different guises. They can be located at very different places within the heart. And it is those variations that have led to the confusion that in many minds still surrounds how to define a ventricular septal defect and how to call them. We believe that it should be feasible to take a very simple system that accounts for all the defects, no matter which heart in which they are found. And it is that approach that we want to share with you today. And we also believe that with our current knowledge of cardiac development, we can provide the evidence that underscores this approach. And many of you who have been with us over the past year or so will have seen this developmental evidence, and I'm going to repeat it today. So, those of you who have been with us, those of you who are about to join, will hear me repeating for you the changing shape of the borders of the channel that we find between the ventricles during cardiac development. And that is one important variable relating to the way we describe ventricular septal defects. But what I'm also going to emphasize today is that there is a second feature that impinges on the way we should describe the various channels. And that is the makeup of the walls between the ventricles. In other words, the makeup of the septum itself. Now, those of you who have been with us previously will know that as we look at cardiac development, when we first see the channel between the ventricles, it's present in the situation where all the blood is coming into the developing left ventricle. Then it has to pass through this initial channel so as to reach the developing right ventricle. So we call that channel, which I'm going to show you again very shortly, the primary interventricular communication. And what I'm going to emphasize again today is that many of the changes we see between the defects depend on the changes occurring during development as the right ventricle achieves its own inlet and as the right ventricle achieves its own inlet, so that primary communication becomes a secondary communication. But then, during development, the aortic root is committed to the left ventricle. And with that change, we see what we call the tertiary interventricular communication. I'm going to stress to you today that tertiary communication is also an aorto-right ventricular communication. And I do believe it is an appreciation of that fact which lets us understand the link between various defects we're going to be discussing. So let's go back to basic cardiac development. Those of you who have been with us previously will recognize this picture by now. It's from an interactive file prepared by my good friends, Wout Blamers, Jill Hickspoors, from the University of Maastricht, the Netherlands. And you see it's in the middle of the 5th week of human development. There you see the atrioventricular canal. And at this stage, it's supported exclusively by the developing left ventricle. And here is the key to the understanding of primary interventricular communication. Because all the blood that's coming into the developing left ventricle has to pass through that channel so as to reach the developing right ventricle, which supports the outflow tract. Now we can look at this arrangement in one of the episcopic data sets that I've shown you so many times. And I'll remind you, these were produced by my other friend and colleague, Tim Mohan, who worked at the Crick Institute in London. Like myself, Tim is now retired, but we're still vehemently interested in understanding cardiac development. And it is these data sets, I believe, that help us understand and see what is going on. Because now I can show you the atrioventricular canal. I can confirm it empties only into the left ventricle. So we know that that channel is the primary interventricular communication. All the blood, the atrial chambers have to pass through this primary foramen so as to reach the right ventricle, which at this stage is supporting the entirety of the outflow tract. Now, the beauty of having this three-dimensional data set is that I can rotate it and I can replicate the oblique subcostal cut that you get all the time in the echocardiographic laboratory. And now you see that in this stage of development, the right atrium has no direct communication with the developing right side of the heart. All the blood has to pass through the left ventricle and come through the primary interventricular communication. And at this stage, we recognize the developing apical component of the right ventricle, but it supports the entirety of the outflow tract. Now, as we will see with ongoing development, the right ventricle will acquire its own inlet. One of those outlets will be given to the left ventricle. But in abnormal development, we can retain the situation that you're looking at the moment, but with the seeding of one of the inlets to the left ventricle. And I hope you will recognize that this is remarkably similar to what we see in tricuspid atresia, where typically there are concordant ventricular arterial connections. And it's also similar to what we see in double inlet ventricle, where usually there are discordant ventricular arterial connections. And now Diane is going to show you examples of these lesions, and I hope you can see the similarity between what we're showing you here, normal human development, and what you see in the malformed hearts, where the interventricular communication is akin to the primary interventricular foramen.
Here we have a heart that shows us the so-called classical type of tricuspid valve atresia. You can see the coronary arteries delimiting the hypoplastic right ventricle. And typically, tricuspid atresia comes with concordant ventriculo-arterial connections with the pulmonary trunk from the right ventricle and the aorta from the left ventricle. This specimen shows us a very nice comparison to the developmental image that Professor Anderson just showed you, where we have the morphologically right atrium and atrial appendage that is somewhat dilated, and our hypoplastic right ventricle. There is no potential in both the developmental image and in this heart for a connection at the right atrioventricular junction, so that the inlet component is absent, secondary to failure of the atrioventricular canal to expand rightward. We still have our apical trabecular component and a well-formed outlet component. And you'll note that this outlet component is nice and elongated with a complete subpulmonary muscular infundibulum. And this is because the outlet or the proximal outflow cushions formed normally. The hole that we see here is a muscular ventricular septal defect. And in both this heart and the developmental heart, it is the primary interventricular foramen, so that this was the only way that blood could get from the left side of the heart to the right side of the heart. Here we're looking at the anterior half of a heart that has a double inlet left ventricle and a rudimentary and incomplete right ventricle. Also, there are discordant ventricular arterial connections, which is typically the case with double inlet left ventricle. Here you can see the coronary arteries following the interventricular septum and delimiting this incomplete right ventricle. This right ventricle lacks its inlet, but has an apical trabecular component and an outlet component. The aortic valve is supported by a complete muscular infundibulum within the outlet component. The ventricular septal defect is large in this case and entirely surrounded by muscular borders. The ventricular septal defect is required to maintain systemic circulation. You'll also note that the outflow component of this rudimentary ventricle is quite short in cases with double inlet left ventricle, because it is the pulmonary valve that gets moved into the left ventricle, and the aortic valve is maintained within the outlet of the right ventricle.
So now we need to move on, because in normal development, the atrioventricular canal expands, and it's that expansion gives the right ventricle its own inlet. And now, as I've already emphasized, that expansion means part of the borders of that primary interventricular communication surround the developing right ventricular orifice. And that means that the remaining channel is now the secondary interventricular frame. And I can show you that in another episcopic data set. As you see, this is from a mouse heart. And now the atrioventricular canal has expanded, and you see that the right ventricle does indeed have its own inlet. So the channel that now persists between the ventricles is the secondary frame. But look at the outflow tracts. There is the pulmonary route, there is the aortic root. Note that beneath the outflow tracts, we have two cushions. They're going to become important very shortly because they are going to build a shelf in the roof of the right ventricle. But the key point at this stage is that both outflow tracts remain above the developing ventricle. The heart at this stage is akin to what you see as double outlet ventricle. And the key point now is that the persisting secondary interventricular communication is an aorto-left ventricular communication. And that, of course, is because at this stage, the aorta persists above the cavity of the right ventricle. And so I can take that data set I showed you just a moment ago, I can cut it in four-chamber fashion, and I can show you the relationship between the developing right ventricle and the aortic root. And you see there is no question, but at this stage, both the aorta and the pulmonary trunk persist above the cavity of the right ventricle. The embryo has double outlet ventricle. And there is the persisting interventricular communication. Remember, it is now secondary foramen because part of the initial foramen surrounds the tricuspid valvar orifice. Now, here is the key, in my mind, for understanding. We can create a triangle of space beneath the aortic root. And at this stage, that triangle is part of the right ventricular cavity. And the secondary interventricular communication relative to that triangle of space is an aorto-left ventricular communication. But you see that there is a much larger communication between the aorta and the right ventricle. And in order to put the aorta into the left ventricle, the embryo has to close that aorto-right ventricular communication. And I've said this on several occasions in our previous presentations. That is what the surgeon does when closing double outlet right ventricle. And that's what now Diane is going to show you.
This heart is showing us a simulated 5-chamber echocardiographic cut where we have the tip of the right atrium here, the right ventricle, the left atrium, and the left ventricle, and the so-called 5th chamber, which is the aortic root just here. If I place my probe along the crest of the muscular ventricular septum, you can see that the aorta is more committed to the right ventricle than it is to the left ventricle. The defect extends to become perimembranous with fibrous continuity along the posterior inferior border between the tricuspid valve and the mitral valve. If we recreate that triangle of space that Professor Anderson has been speaking about, you can see that it extends from here to the crest of the septum and then back to the ventriculoinfundibular fold, so that this space here is now the remodeled secondary interventricular communication, and it becomes the left ventricular outflow tract or the aorta to left ventricular connection. This area is where the surgeon will place their patch between the crest of the ventricular septum and the ventriculoinfundibular fold to put the aorta back into the left ventricle. But you can see that this line here is the aorta to right ventricular communication.
So, when the surgeon seeks to correct double outlet right ventricle, he or she puts a baffle in the roof of the right ventricle so as to tunnel one or other of the arterial roots into left ventricle. And that is exactly what the embryo does so as to put the aortic root into the left ventricle in normal development. And the embryo does that by fusing together those proximal outflow cushions. And then the space belonging to the right ventricle becomes part of left ventricle. And we can see that in action. So here is another mouse embryo. It's a little bit later in development, the one I showed you a few moments ago. You see, developing right ventricle. And now at this stage, those cushions that were forming in the roof of the right ventricle, there you see them, one parietal, one septal, they have fused together. And in so doing, they create a tunnel in the roof of the right ventricle between the aortic root through secondary interventricular communication. Remember, that was an aorto left ventricular communication. But now, by building shelf, the aortic root is committed to the ventricle. But those cushions do not do the entire job. They build that shelf, but at the back part of that shelf, there is a persisting space, and that is the aorto right ventricular communication. And we can consider that now as a tertiary interventricular communication. So let me show you why. This is that same data set. I've cut it just a little bit more posteriorly so that you can see the aortic root. There is the left ventricle. And now we can put in our triangle space. You'll remember that it belongs to the right ventricle. And the secondary interventricular communication is the aorto left ventricular communication. But there is that second space. It is between the aortic root and the right ventricle. We can call it aorto right ventricular communication, but very shortly, that space beneath the aortic root is going to belong to left ventricle. So we can also consider that space, aorto right ventricular communication, as the tertiary interventricular communication. And it is that communication, the tertiary interventricular communication, is closed by the cushions, the tubercles of the atrioventricular cushions, and it becomes the membranous septum. And by closing that space, the triangle I showed you just a moment ago becomes part of the left ventricle. And I can show you what has happened in a human embryo. There is the pulmonary root. We're looking at a 4-chamber section. And there is the tunnel connecting the aortic root to the left ventricle. And beautifully there, you see how the tubercles have closed that tertiary interventricular communication, the aorto right ventricular communication. And by so doing, they turn secondary interventricular communication into the left ventricular outflow tract. And that completes normal development. So now, right ventricle has its own inlet, the left ventricle has its own outlet. But we can still get channels if things go wrong. And that is what we call ventricular septal defects. So here is now how we have to consider the additional feature of septal makeup. Because in the normal ventricular septum, the large part is muscular. The membranous septum is very small. Those proximal cushions which built that shelf in the roof of the right ventricle, if all goes well, they become the freestanding infundibulum. They are no longer septal. But these processes can go awry. And that is what produces the lesions we now need to discuss. There can be problems even with formation of the muscular septum. Many people think that trabeculations we see during development come together to form the ventricular walls. This is not correct, but they do coalesce to form the muscular ventricular septum. And if that process of coalescence goes wrong, then holes can be found anywhere within the muscular septum. And if the process is widespread, we see what is called the Swiss cheese septum. And we know that this can happen. We have a colony of mice in which Dr. Mohan perturbed the furin enzyme. I'm going to show you other examples examples from this colony of mice, but this is an important one because, as you see here, the septum has not coalesced properly, and it looks pretty much like a sponge or a Swiss cheese. And this is what happens in human development when we get those multiple ventricular septal defects. Diane is going to show you now the Swiss cheese septum.
Both the right and left ventricular free walls have been cut away, essentially creating a window so that we can look at the muscular interventricular septum. Here you'll note that there's already one visible defect towards the apex of this right ventricle. And if I use my light, you can see that there are multiple other defects associated with this larger defect. And this is secondary to failure of the trabeculations to coalesce during development. And these multiple defects towards the apex, and actually in this heart extending into the mid component of the septum, give us the so-called Swiss cheese type of ventricular septal defect. If we look at this from the left ventricle, also you can appreciate the increased trabeculations and the multiple defects that are occurring throughout the apical component of this left ventricle. Again, I can put the light on to show all of the defects that are within the apical component of the ventricular septum. Here's another specimen that shows us yet another muscular ventricular septal defect, this one occurring within the inlet component of this morphologically right ventricle. So it's beneath the septal leaflet of the tricuspid valve, and it's a fairly small defect. Also, you'll see that there is a perimembranous defect, and we'll look at this heart a little bit later in the presentation. This next specimen shows us the position of more muscular ventricular septal defects, this one within the outlet component, and then several at the apical component of this right ventricle. When we view them from the left side, here you can see all of the muscular rims around this outlet defect, and there are the apical defects, so that you can have muscular ventricular septal defects anywhere over the muscular or apical component of the muscular interventricular septum.
Now, there can also be problems with formation of the subpulmonary infundibulum. If all goes well, the cushions fuse, they muscularize, they become the infundibulum. But should they not fuse with the septum, they can persist as the muscular outlet septum, or they cannot muscularize at all, and then that gives us a very important defect, which is juxta-arterial. We can look at that in two steps. First of all, I can show you this section from a human embryo, again, an oblique subcostal section, and you can see the cushions which separate the aortic root from the infundibulum, and they are about to fuse. And that, again, is the aorta-right ventricular communication, the tertiary foramen. Now, if they don't fuse, they can persist as a muscular outlet septum. And we see that beautifully in this piece of tissue I have removed from a patient who had tetralogy of Fallot. It replicates the image I showed you just a moment ago. And there you see those cushions that now have fused, they have muscularized, but they have not become part of the normal septum. So part of them persists as a muscular outlet septum, and then you see distally we have the freestanding infundibulum. And this is the typical feature we see in tetralogy of Fallot. But sometimes they don't muscularize at all. And then this we can see again in another of the mice from the Furin column. There you see the aortic valve, pulmonary valve. The cushions have fused, but they have not muscularized. So the space that should be filled by the infundibulum leaves itself open instead as a juxta-arterial defect. And so now we're going to look at the juxta-arterial defect, and we're going to see what happens when those cushions do not fuse.
Here we're looking at the outflow tract of a morphologically right ventricle with concordant ventricular arterial connections. And you can see we're looking at the opened pulmonary valve here. This is a juxta-arterial defect where we have fibrous continuity between the pulmonary valve and the aortic valve in the roof of the defect, along with a fibrous outlet septum. And this fibrous outlet septum is occupying the space that should have been occupied by the subpulmonary muscular infundibulum. And this defect occurs secondary to hypoplasia of the proximal outlet or outflow cushions. And it also prohibits the pulmonary valve from being lifted up off of the right ventricular mass by that subpulmonary muscular infundibulum. Because of this failure, the arterial valves remain at the same level, and we get that fibrous continuity between the arterial valves at the roof of the defect. These defects can extend to become perimembranous, as this one does, where we have fibrous continuity along the posterior inferior border between the tricuspid valve and the mitral valves. If we look at the left ventricular aspect of this defect, there is some posterior malalignment of that fibrous outlet septum with some subaortic stenosis. Here along the posterior inferior border, you can see it does extend to become perimembranous, where there's fibrous continuity between the tricuspid and the mitral valves. You can also have a subarterial defect with a posterior inferior muscular bar, and this heart is in the same orientation as the last specimen, but you can see that the caudal limb of the septomarginal trabeculation reaches back to the inner heart curvature and joins the ventriculoinfundibular fold. The defect has at its roof fibrous continuity between the pulmonary and the aortic valves, and there is a fibrous outlet septum. Here we have a muscle bar in between the tricuspid and the mitral valves, as we'll see from the left side. And again, we have posterior malalignment of that fibrous outlet septum in this area where the aortic valve and the pulmonary valve are in fibrous continuity. But you can see the nice muscular rims around the borders of this defect, separating the atrioventricular valves from one another.
But they can, in the previous moment I said they do not fuse. Of course they do fuse. What I meant to say, they do not muscularize. But on occasion they can come together and they can muscularize in part. So if they don't fuse at all, we have the juxta-arterial defect. And then in that setting, most of the defects have a muscular postero-inferior rim, and that is formed by the coalescence of trabeculations. But on occasion, the outlet septum can be formed, but can be hypoplastic. And then that gives us a muscular outlet defect. And now we're going to look at the muscular outlet defect.
Here we're looking at a right ventricle opened in clamshell fashion, so we can see the tricuspid valve in the inlet and the pulmonary valve within the outlet. And here we can see that there is a ventricular septal defect that is within the outlet component of the right ventricle. So whether the defect has muscular rims or extends to be perimembranous, an outlet defect is defined by extending between the limbs of the septomarginal trabeculation. So you can see the cephalic limb extending here to become part of the subpulmonary infundibulum, and the caudal limb along the posterior inferior border is reaching the inner heart curvature, so that there is muscle separating the tricuspid valve from the mitral valve along the posterior inferior border. The aortic valve in this case is actually prolapsing through the roof of this defect a little bit. So the outlet defect occurs between the limbs of the septomarginal trabeculation, but it's also important to note that we have our subpulmonary muscular infundibulum that was formed by the proximal outflow cushions. If we look at the left side of the defect, here you can see along the posterior inferior border that nice muscular bar that separates the tricuspid valve from the mitral valve.
So let's presume now that in fact all has gone well. And if all had gone well, there would have been closure of the tertiary communication. And what I've already shown you, if that goes according to plan, the tubercles commit the aortic root to the left ventricle, and then they form the membranous septum. But what happens if everything proceeds normally to that stage, but the cushions simply fail to close that foramen? Then we have an aortopulmonary foramen, aorto-right ventricular communication, bounded posteriorly by continuity between the leaflets of the mitral and tricuspid valves. And this, of course, is the perimembranous defect. Once more, we can turn to our furin colony of mice, because they show us exactly what is going on. So yet another of the mice from that colony in which Dr. Mohan perturbed the furin enzyme. You'll recognize, I hope, that I'm showing you again the 4-chamber section incorporating the aortic root. And there is the tunnel we were talking about, where the embryo is trying to commit the aortic root to the left ventricle through the remodeled secondary interventricular communication. But in this mouse, the aorto-right ventricular communication remained unclosed, and it is bounded posteriorly by fibrous continuity between the leaflets of the tricuspid and mitral valves. Note, however, there is discontinuity between the leaflets of the aortic and tricuspid valves. So now we know phenotypic feature, perimembranous defect, is tricuspid to mitral fibrous continuity. Now I can also show you another important point, because I can now put in my triangle of space once more. Because as the aortic root is committed to the left ventricle, so the secondary interventricular communication becomes the aorto-left ventricular communication. And that is now the outflow tract for the left ventricle. But we have left behind the aorto-right ventricular communication. And it is the aorto-right ventricular communication that is now the perimembranous defect. And Diane now is going to show us the features. This perimembranous defect, which is the right ventricular border of the triangle of space beneath the aortic root and the left ventricle.
This specimen is another that is cut in that simulated 5-chamber echocardiographic plane, so that we have our right atrium here, the tip of our left atrial appendage, tricuspid valve and right ventricle, and there is the aortic leaflet of the mitral valve and the left ventricle. So you can see the crest of the muscular ventricular septum, and there was a tiny perimembranous ventricular septal defect here. I noted it because of the billowing of the tricuspid valve just in the area adjacent to the defect. And you can see the area of fibrous continuity here between the tricuspid and the mitral valves. And if we recreate that triangle that Professor Anderson has been talking about, we can see that it is created in this area with the aorta right ventricular entrance or communication, a much smaller line in the plane of that triangle than is the left ventricular outflow tract, which was the remodeled secondary interventricular communication during development. And once the aorta was put back into the left ventricle during development, that became the left ventricular outflow tract, or was remodeled to become the left ventricular outflow tract.
So what we've shown you now is that failure to close the tertiary communication gives us perimembranous defect, and that defect, in essence, is an aorto-right ventricular communication. Diane has shown you one which opens centrally, but depending on which part of the muscular septum is deficient, depending on what is going on in the outflow tract, those perimembranous defects can open either into the inlet, the outlet, or, if very large, they can become confluent. But always, they represent failure to close that aorto-right ventricular communication. So now let's look at the variation in the perimembranous defects according to the deficiency of the components of the muscular septum.
This right ventricle has been opened in clamshell fashion, so we can see the tricuspid valve in the inlet and the pulmonary valve in the outlet, supported by a complete muscular infundibulum. Here is our septomarginal trabeculation with the cephalic arm rising up to become part of the subpulmonary muscular infundibulum, and the caudal limb reaches the inner heart curvature with the medial papillary muscle arising from that caudal limb. Here we can see that the supraventricular crest has inserted itself normally between the limbs of the septomarginal trabeculation. Looking at the inlet component of the right ventricle, we can see that there is a ventricular septal defect that extends into the inlet component and behind the septal leaflet of the tricuspid valve. There is fibrous continuity along the posterior inferior border between the mitral valve and the tricuspid valve, making this defect perimembranous. And I also want to point out that this area is the aorta to right ventricular communication. When we look at an outlet perimembranous ventricular septal defect, this right ventricle has been windowed. So here is our complete subpulmonary muscular infundibulum. And the defect is an outlet defect because it extends between the limbs of the septomarginal trabeculation. It extends to become perimembranous with fibrous continuity between the tricuspid and mitral valves along the posterior inferior border. And as I mentioned previously, it is an outlet defect because it extends between the limbs of the septomarginal trabeculation. This outlet defect is as a result of malalignment of the outlet septum during development, so that the proximal outflow cushions are now divorced from the inner heart curvature or between the limbs of the septomarginal trabeculation. I'd also like to point out that this is the aorta to right ventricular communication. If we look at the left aspect of this defect, we can see that there was some degree of posterior malalignment of the outlet septum, with this muscle bar separating the tricuspid valve from the aortic valve, but we can see the perimembranous extension here between where there's fibrous continuity between the tricuspid and mitral valves.
We've also seen that the juxta-arterial defect can become perimembranous, but on occasion that happens when the right ventricular trabeculations do not close so as to fuse with the inner heart curve, and it's only when they do coalesce, fuse with the inner curve, that we get that muscular postero-inferior defect.
This is a perimembranous ventricular septal defect that also extends to become juxta-arterial along the posterior inferior border. It is perimembranous because we have fibrous continuity between the tricuspid and mitral valves, and it is juxta-arterial because we have fibrous continuity at the roof of the defect between the pulmonary and the aortic valves. This defect is an outlet defect, in part because it extends between the limbs of the septomarginal trabeculation, but because the subpulmonary infundibulum failed to form, so that the pulmonary valve could not be lifted up off of the right ventricular mass, allowing for the pulmonary valve and the aortic valve to remain at the same level, hence the fibrous continuity between the two arterial valves at the roof of the defect.
We now need to take into account another very important feature of these defects, and that is malalignment. And malalignment, as we will see shortly, take two types. but most usually it depends on malalignment of the outlet septum. When the outlet septum is malaligned, and remember, the outlet septum is formed by muscularization of fused cushions, the tubercles, the atrioventricular cushions, will not be able to close that aorto-right ventricular communication. And so a very important feature is malalignment between the components of the septum that normally come together. And as I say, most usually it is the outlet septum that is malaligned, but significantly, that malalignment can be cranial caudal. If the malalignment is cranial and the outlets themselves retain their equality in sizes, then we get what is called the Eisenmenger defect. Whereas if we get caudal malalignment, then that blocks the outflow tract from the left ventricle, and typically we then see coarctation or interruption of the aortic arch. So now Diane will show you these features.
Here we'll compare a couple of malalignment outlet defects. This view is from a right ventricle that has had the free wall removed, aside from the subpulmonary muscular infundibulum, which we can see is nicely formed and supporting the pulmonary valve within the right ventricular outlet. Here we see a ventricular septal defect that does extend to become perimembranous, as there's fibrous continuity between the tricuspid and mitral valves along the posterior border, posterior inferior border. Also, this defect extends between the limbs of the septomarginal trabeculation, making it an outlet defect. In this particular specimen, the outlet septum is a prominent structure and is malaligned in anterior superior position. This specimen is consistent with the so-called Eisenmenger type of ventricular septal defect, where there is no subpulmonary stenosis. We can see the same type of malalignment outlet defect in those hearts with tetralogy of Fallot, but of course we all know those patients have subpulmonary stenosis secondary to the anterior deviation of the outlet septum and the hypertrophy of the septoparietal trabeculations. If we look at this defect from the left ventricular aspect, the aorta does slightly override the ventricular septum, and here we can see the nice fibrous continuity between the tricuspid and the mitral valves along the posterior inferior border. And if we go back to the right side, as we've been discussing today, this is the aorta to right ventricular communication. If we look at a specimen that has caudal or posterior deviation of the outlet septum, again, this right ventricle has been windowed, and we can see the pulmonary valve supported by a complete muscular infundibulum. This portion of the subpulmonary infundibulum looks a bit small to me, and it's also deviated in caudal fashion. The defect extends between the limbs of the septomarginal trabeculation, and it does extend to become perimembranous, with fibrous continuity between the tricuspid and mitral valves along the posterior inferior border. Again, this defect, or this area here, is the aorta to right ventricular communication. Looking at the left component, or the left side of this defect, we can see that caudal malalignment of the outlet septum, so that there is some degree of aortic stenosis. The defect does extend to become perimembranous with fibrous continuity between the mitral valve and the tricuspid valve along the posterior inferior border. And this is now the definition of a perimembranous ventricular septal defect, because you can see that this muscular bar separates the tricuspid valve from the aortic valve, or I should say this muscular outlet septum. These specimens typically will have an associated coarctation, or as we see in this particular specimen, we have an interrupted aortic arch with the ascending component of the arch, bifurcating into the brachiocephalic trunk and the left carotid. And here we see the pulmonary trunk with the arterial duct communicating with the descending aorta, where we see the left subclavian branching from the distal aorta.
But there is another very important type of malalignment, and that is malalignment between the muscular septum and the atrial septum. And this reflects incomplete expansion of the atrioventricular canal. It's very important. It's found in the setting of perimembranous defects, and it is important because it is associated with straddling and overriding of the tricuspid valve. So let's now look at a heart that has a different type of malalignment, atrioventricular septal malalignment, in the setting of a perimembranous defect.
This specimen was initially opened by following the flow of blood, and you can see that the arterial trunks are spiraling normally from the ventricular mass, even though, as we'll see in a moment, that this specimen did have a double outlet from the right ventricle. The specimen was put back together so that we could cut it in a simulated 4-chamber echocardiographic plane to show the abnormality. Here we're looking at the inferior aspect of the heart, where you can see the pectinated morphologically right atrium, and here is the smooth-walled vestibule of the left atrium. In between is the flat valve at the floor of the oval fossa with the muscular buttress, and we can see the tricuspid and mitral valves are separate structures. The tricuspid valve is quite dysplastic in this case, and it is straddling and overriding the crest of the ventricular septum with a papillary muscle supporting it within the left ventricle. If I place my probe along the expanse of the muscular interventricular septum, you can see that there is indeed atrioventricular septal malalignment. There is a bit of ventricular muscle here separating the tricuspid valve from the mitral valve. But if we look at the anterior aspect of the heart, so now we're looking from the sternum, from the spine towards the sternum. Here we can again see the atrial septum, or the flat valve at the floor of the oval fossa, and the muscular buttress separating the tricuspid and mitral valves into two separate atrioventricular valves. If I lift up here, we can see that this defect, even though there is straddling and overriding of the tricuspid valve, extends to become perimembranous with fibrous continuity in this area between the tricuspid and mitral valves. And here you can see where the aortic valve is arising from the morphologically right ventricle to the right side of the muscular interventricular septum.
So now we've put together the morphology. I hope we've shown you that channels between the ventricles can have different borders. They can open into different parts of the right ventricle, and we can understand all of that. Now we appreciate what's going on in normal cardiac development. But now we need to concentrate a little more on those borders, because it is the borders that determine phenotypic variability, and crucially, that tells us where we're going to find the atrioventricular conduction axis. Now, you all know the atrioventricular conduction axis is the solitary strand that joins together the atrial myocardium with the ventricular myocardium. And the ventricular part of that axis is carried on the crest of the muscular septum. And usually it originates from the atrioventricular node. Hopefully by now you're all aware the atrioventricular node is found in the triangle cock, except when there is atrioventricular septal malalignment. And that is why that defect with straddling and overriding of the tricuspid valve becomes so important. So on this basis, we can establish some rules. So let's look at the normal heart. There is the atrioventricular node. It's at the apex of the triangle cock. And having penetrated, the bundle is sandwiched. Membranous septum formed by the tubercles, the atrioventricular cushions, and the muscular septum. And it emerges in the right ventricle beneath the medial papillary muscle. So if we draw a line from the apex of the triangle of Koch, medial papillary muscle, that gives us a good indication of where we're going to find the atrioventricular conduction axis. So now, let's put in the various muscular defects. And you see the relationship, the defects to the atrioventricular conduction axis will vary depending where they are within the septum. And the important one is the muscular inlet defect. So as you see, that is inferior to the conduction axis. There is the other hole, that is the muscular outlet defect. And that is superior to the axis, and it is protected from the conduction system by that muscular postero-inferior rim. But when we have retention of that aorto-right ventricular communication, the perimembranous defect, always we know the conduction axis is going to be postero-inferior. And then finding that line between the apex and the triangle of Koch and the medial papillary muscle tells us where we will see the conduction system. But there is that one exception, and that is where we have straddling and overriding tricuspid valve, because there, the conduction axis carried on the crest of the ventricular septum is no longer able to reach the regular atrioventricular node, and instead it takes its origin from an abnormal atrioventricular node positioned posterior-inferiorly within the right atrioventricular junction. So let's look now at all these variations as we see them in the heart's cells.
This is a specimen we saw earlier today that has a muscular inlet ventricular septal defect and also a perimembranous defect extending into the outlet of the right ventricle. In order to locate our atrioventricular conduction axis, we can mark the borders of the triangle of Koch. Here you see the flat valve at the floor of the oval fossa and a very minimal eustachian valve in this specimen. If we tug on that, it typically gives us notice to where the tendon of Totaro is, which will run down to meet the tricuspid valve hinge point, which makes up a second arm of the triangle of Koch with the coronary sinus orifice at the base of the triangle. So your atrioventricular conduction axis is typically at the apex of the triangle of Koch, and if we draw a line from that apex to the medial papillary muscle, this is where the right bundle branch will emerge relative to that medial papillary muscle and then extend down the septomarginal trabeculation. Relative to this muscular inlet defect, the conduction axis is well away from it and in anterior superior position. The danger zone for surgeons would be with a perimembranous ventricular septal defect that the conduction axis will extend along the posterior inferior border. If we look at another defect that extends into the inlet component of the right ventricle, here we see the flat valve at the floor of the oval fossa, and there's the coronary sinus. And if we look at the hinge line of the tricuspid valve relative to where the defect extends beneath that septal leaflet of the tricuspid valve, we can see that there is no place for the atrioventricular node to have formed. The apex of the triangle of Koch in this particular specimen will be attenuated or pushed inferiorly so that the conduction axis will be located where the crest of the muscular ventricular septum meets the atrial musculature. So we have an attenuated triangle of Koch in this type of specimen with an inlet perimembranous ventricular septal defect. Again, the posterior inferior border is the important border for the surgeon. The left, or so I should say the non-branching bundle will run preferentially along the crest of the left component of the interventricular septum, with that right bundle branch emerging somewhere along this anterior superior border. Looking at the left side of this large inlet perimembranous ventricular septal defect, here we see the extensive area of tricuspid to mitral fibrous continuity, also with tricuspid to aortic valve fibrous continuity. And in this area is where you'll have the long non-branching bundle that will eventually branch into the left bundle branch and ramify over the crest of the ventricular septum. The last specimen we need to compare in this group is also one we've seen previously that has the straddling and overriding of the tricuspid valve. So this is a defect also within the inlet component of the right ventricle. And in this specimen, we will have an anomalous atrioventricular node because, again, there is no place to form a normal apex of the triangle of Koch. So here's the crest of the muscular ventricular septum, and the atrioventricular node will be anomalous up in this area where the muscular ventricular septum meets the atrial wall. Again, you'll have a long non-branching bundle that will extend along the crest of the ventricular septum and eventually branching into the right and left bundle branches.
So now we can put everything together. Those channels we've been looking at, which permit shunting between the ventricles, are the commonest congenital lesions. And I hope you've now seen we can use the same system for their categorization in all segmental combinations. And that's what we're going to be doing next year as we move on to tell you phenotypic features of all these combinations. So when we find a defect in these settings, we need to take note of their borders. That depends very much on the expansion that we've seen during normal development. We need to take note of their geography. That depends very much on what's happening in the septum itself and the deficiencies in the septum, what is going on, the outflow tract, and then we need to take note malalignment. Remember, malalignment usually in the outlet, but one key feature, atrioventricular septal malalignment. So all of these are important, but of paramount importance is the borders, because it is the difference in the borders that determines the phenotypic variability, and that is what gives you that crucial information regarding the location of the atrioventricular conduction system. Okay, well, we had one or two people who have been with us, not many, but our presentation will be available on the YouTube channel. So Norman, over to you for comments on what you think of the presentation that Diane and I have put together to demonstrate the different types of ventricular septal defect.
I thought it was absolutely outstanding, and for me, of course, it reinforces my education and understanding very beautifully. The thing that I thought was beautifully illustrated today, that we haven't really considered much in the past, was that defects can be of both one and another type. For example, malalignment with perimembranous, or inlet with perimembranous, or outlet with perimembranous defects. And the malalignment of those two segments was so beautiful. Indeed, today, I think the first time that I saw a doubly committed and juxta-arterial defect that also had a perimembranous extension. And I think that this is the lesson for me from today's presentation, that defects can extend from one place to another, and that, of course, if you look at the borders of the defect, you get that very, very clearly. So that is certainly my main point of comment for today, is the enlightenment that I've received from the fact that defects, if you describe their borders distinctly, you can believe that the defects are not only situated as one or other type, but that extend across the various classifications.
I mean, the
And I
point you
think that
make,
is
Norman, is so important there. I'm working with colleagues in India at the moment, and we're looking at Tetralogy of Fallow, which is going to be our next presentation. The first presentation in 2024 will be Tetralogy of Fallow. And it's interesting to me that many people presume that in Tetralogy of Fallow, the malalignment defect is always the same. But the point you've just made is particularly important in tetralogy, because as you say, the defects in tetralogy, although they're malalignment, are usually perimembranous, but they can have a muscular posterior inferior rim. They can extend to become juxta-arterial. So the point you've just made is going to be so important as we move on in 2024 and we look at the different defects. And when we look at double outlet, we will find the same thing. When we look at transposition, we will find that the defects, even if they're malalignment, can be perimembranous, can be muscular, very rarely can be juxta-arterial. So I think the point you've emphasized there is really what is the key point that we've been trying to emphasize today. All of the defects are either perimembranous, muscular, or juxta-arterial, but they can appear in so many different guises and in so many different locations.
Right. Absolutely. In fact, in the west coast of the United States, we have a large Hispanic population, and many of those patients have defects in tetralogy where there is hyperplasia of the developing infundibular septum, and we call those Mexican tetralogies. But I think that just shows you that you can get a variety of defects which are phenotypically of the same variety, but need to be augmented with a clear description.
Absolutely. Adrian, I'm glad to have you with us today. I hope you have some comments having seen the presentation.
Thank you. Thank you very much. I hope you can hear me.
Yes, indeed.
First of all, Prof, if I am allowed, I have to congratulate Diane.
Absolutely.
First
Yes.
and foremost, because the specimens are exquisite. And the way she presents them, the way she shows for clinicians the important areas, the borders, is really spectacular. Diane, you are doing a wonderful work with these specimens. And I know what it means because I also deal with specimens, and it's very difficult to prepare such a quality presentation. Really,
Yeah.
Congratulations.
Yeah.
Thanks, Adrian.
The second thing would be, there are so many things to take out of the presentation. Why, for example, the term bulboventricular foramen is wrong, because this is interventricular communication, not bulboventricular communication. There are two ventricles. I wouldn't be too much worried about the presence today because it hasn't been re-advertised. You know, we are before Christmas. The important thing is that this is saved. This is it can be accessed later on. The idea of the channel, I think it's good to emphasize this again and again, and the two entrances to the channel, and where are the fibrous borders, because when we talk about fibrous border, we look either from the right or from the left, but it's actually the entirety of the tube in one area where it's fibrous. That, I think that's important to emphasize that, because sometimes people understand that it's only on one side of the tube, of the channel. And this was the problem with tricuspid to aortic continuity, I think. That's why tricuspid to mitral makes much more sense, because it really goes across the channel, this continuity.
Very good point you make, and Adrian, and also I should emphasize again how important Diane's presentations were. I should tell you that Diane made the presentations aside from me having made my presentation, and they fit together so beautifully. So Diane, over to you. Do you have some comments? I see you have Q there with you, and is that Ron with you also?
Not just at the moment. He's off in another room.
Well, Q, nice to see you. Were you able to be with us for the larger part of the demonstration?
Yes, we joined a little bit towards the end, but yeah, I would totally agree. I mean, we are just so happy to have Diane here to kind of, be, showing those kinds of specimens and with her video demonstrations. I mean, to see that, to be able to kind of, just know what you're going to see when, get into the real case is just extraordinary. And her examples are just tremendous. And the other thing,
I'm sure you would reinforce what Adrian says from the
Absolutely.
surgical stance.
Yes, I mean, you could just envision your suture placement, going around those defects and just, very precisely, avoiding, conduction and weaving in and out of the, the subvalvular apparatus. I mean, it's just a great, visual to be prepared to do a case, especially for our younger faculty. So excellent.
And I know, Q, you've always noted that in tetralogy you can have these different types of defect, whether they're perimembranous, whether they're muscular, but it surprises me that still many surgeons seem to be unaware of that difference.
It's in the textbooks. 20% should be outlet type defects, and then the ones that are doubly committed. I'm not sure the incidence of those and what the ethnicity of it, but I mean, we see them, and it's I think the important thing is that the nomenclature or what you're describing, is not exclusive. It's just you're describing different aspects of the defect, and they can be all together. And perimembranous and outlet, or perimembranous and inlet, all that. I mean, that's just just part of the descriptions of these lesions, and I think that I don't know, Norman, that wasn't new for me. I must say that's what I was always taught, but it is it's part of our anatomy in terms of knowing to approach the defects.
Let's
Bob,
say,
I've got a few more things I want to say.
Q, you're one of the enlightened.
Can I just ask Q, traditionally we believe that if we see a doubly committed and juxta-arterial defect, that the surgeon will probably approach that defect from the pulmonary valve aspect, or from the outlets, and the perimembranous VSD through the tricuspid valve. How do you approach a patient like the one that Diane showed us, that has doubly committed defect, which extends perimembranous? Do you have to go in both ways to put the patch in there?
Well, we can. It depends what we're doing. If we do a tetralogy and you're doing a transventricular approach, which a lot of folks do, you can just address it right there. If it's if you're doing it through the pulmonary valve, right, you're working down into the ventricle, and you're securing the superior aspect of the patch to the hinge point of that right side of the pulmonary valve right there, and you're working from above downward. So it just depends on what the case kind of dictates in terms of what needs to be closed in from which approach.
Diane, do you have any points to make? I mean, as everybody's been saying, the demonstrations are getting better all the time. We're looking forward next year to now expanding this into the different lesions, and hopefully we can convince everybody what the phenotypic variation is. Do you have any thoughts before we leave?
Can I make one more point, Bob? After Diane.
Does Diane have anything to say?
No, not really. I just it's nice to work with Q, because he's very visual, and we looked at a few hearts last week for a surgery he was trying to plan. So it's very helpful to have the specimens here to look at, so that he can get in his head what he wants to do or has new ideas, and I'm glad to be able to help with that.
Norman.
Yes, Bob. So everything was very clear today, but there is a little dilemma that has been interjected by the International Nomenclature Committee, of which you are part. And I'd like you perhaps for the future, for reference, to resolve for us why we should actually pay any attention to the International Nomenclature Committee. I know it's easy for me. I just ignore it completely. But I think that a lot of other people would want to know about that. And so I would leave you with this challenge to resolve it in a way that makes sense for all of us.
Well, it's true, Norman, that as yet we don't have consensus. I would not wish to move particularly in that direction, but to me, and I know that Adrian and Diane support me 100% in this regard, we believe that it is the evidence that should determine the phenotypes. And I think that you have seen today, and what Adrian has been saying, that Diane now is demonstrating the evidence, and for the phenotypes, it depends very much on the anatomy. And that's really what I'm hoping to do as we move forward into next year, because we'd like to show you the evidence that underscores the approach that we take, because it is true, we are still not yet in the realms of total consensus. But it is, I believe, the evidence that must now be the master. And so as we move next year to look at the different phenotypes, we're going to try to show that evidence. Adrian.
I was just wondering whether our participant would like to ask anything, because I know there is someone in the chat. So if there is a chance for that.
There is indeed, but we don't have anything in the chat at the moment.
Okay.
So I think we should take this as our final presentation for 2023. It's the way forward. And I'll take this opportunity to thank all of you for being with us today. As Adrian has emphasized, the material is now available on YouTube. We should thank Sasha for putting it all together, stitching it together to make my presentation meld so perfectly with Diane's presentations. That's all down to Sasha. So we thank Sasha, we thank the Congenital Heart Academy, and we wish you all a wonderful festive season. We hope that things improve across the world, and we look forward to seeing you all next year. So thank you for being with us, and let's look forward to next year.
Season's
Gentlemen,
greetings to
ladies,
all, and congratulations to Diane for her brilliance today.
Absolutely.
All the best.
All the best.